think I'm on today.
Oh, I can hear you. Yes.
Don't know what happened.
You're rolling.
Yes,
You're
sir.
crystal clear.
Put those exercises at the carpal tunnel so that we
I emailed them.
Hey, if Randy needs it, I can send it to him right now. Jill, I have that if Randy needs me to send it to him. I can't hear you. I muted you. Sorry.
I have it too, so I can send it to him.
It's darker and darker and darker.
Yeah.
Good deal. Lisa's got a different haircut today.
To me and him.
Is that intentional or on purpose?
It just looks weird.
I didn't hear you there. Was that intentional or on purpose?
What?
Your different hairstyle today.
No, it's I don't know. I got it cut a couple weeks ago, but yeah, it's about the same. So.
All right. Well, good. Kathy, what's good today? All right. This is my second time seeing you today.
Well, at least I can hear today. That's a really good thing. I don't read lips well, so
Yeah. That could be good or bad.
yeah.
So good. Jill, what's good?
Oh, June's over with. I'm back to work. So
Rocking and rolling.
stuff should be slowing down a little bit as far as the schedule, and the summer can happen.
Mhm.
So ready for it to stop raining so we can go to the lake.
Holy smokes. I looked yesterday and there wasn't supposed to be rain today. And I'm
Right.
so glad I mowed the grass yesterday, because
Yeah.
nowadays, any chance you get to mow the grass, just do it. It's never
Yep.
what the next chance to be.
Yep. We got on the lake a little bit on the 4th between rainstorms. Kids went tubing and stuff, so they were freezing, but it was still fun. So
Yeah. So I'm going to keep muting you because you got some loud company over there.
I got a lot of people in the office. Yeah,
So, lay the hammer down.
it's fine.
Susie, what's good?
It sounds like the rain might be done for the day, I hope. I see a little ray of sunshine out there.
Okay. Well, I guess that's good. I mean, the upside is that we don't have to water our grass, and you don't have to worry about, your garden just dying because it doesn't have enough water.
Yep.
I haven't even had to really pull out the hoses and really go to town this summer yet. So fire danger's low.
Yep.
That's good. Yes.
So not too bad. I'm not sure who is on the bottom of the screen here. iPhone 4, it says trying to connect to audio. I don't know if that's Kelly or if that's somebody else trying to sneak in there, but looks like they're not able to connect. So anyways, Lisa, I left you out there. What's good?
It's sunny. It's very nice, beautiful sunny day over here. So I guess you got the rain that we had maybe a couple of days ago. So, but yeah, it's great. Perfect. And, I think everybody's happy that it's summer, or at least, well, maybe not quite for you guys today, but yeah.
Have you been getting all the rain over there towards Seattle too?
It's, we had some rainy weather last week. Yeah, I mean, kind of, actually most of 4th of July weekend was raining. It was, it was kind of weird, but that's good because, the idiots who are throwing fireworks and stuff sometimes set people's roofs on fire. It's better if it's a little wetter. So yeah, so it was rainy and wet and cooler. So I think that's the best way.
Okay. Well, we'll take it. Well, did you guys see what the topic is today?
Yep.
So good. And this is a good topic because we've been hitting a lot of shoulders recently in our VPT program. So we've had quite a few people that have been looking at developing a little bit of shoulder pain, developing some bit of pinching that is occurring in their shoulder. They've been developing more tenderness with overhead activity. So obviously we don't want shoulder pain. We don't want that at all, especially when we're strength training or lifting, but sometimes it occurs in your normal daily life. sometimes all of a sudden you don't realize what happened and you're going, geez, just to reach up overhead, I'm getting pain. Or you wake up from a long sleep and you're going, why is my shoulder sore? And it has this little pinch that feels right kind of superficial in the front of the shoulder or a little bit off to the side. And it just kind of pinches with select activity. So what do? You start favoring it. You start babying it a little bit. You're not using it as much. And you think you're out of the woods until you start working up overhead and you're going, or you lift something out to the side and you go, gosh, it's been like a month and that's still not gone. What's going on? So what we're really hitting on today and what I'm alluding to is shoulder impingement. And shoulder impingement is the number one injury to the shoulders for individuals across the United States. Anytime that they're studying shoulder injuries, shoulder impingement is always number one. So what are we really looking at with shoulder impingement? You know, a lot of times you hear about shoulder impingement issues with swimmers. You hear with baseball players, throwers, softball players, activity. But it really involves the rotator cuff. And what we're going to get into today is I'm going to show you some anatomy. I'm going to show you a little bit of why we're getting shoulder impingement issues, how it occurs. And then through that, we should be able to start talking about ways to alleviate it, or at least avoid it when you're working out or doing home chores. Okay. So before we kind of get going, let's kind of talk about a base level of what we're talking about. We're really talking about rotator cuff muscles. So let me share my screen real quick. And I'm going to go to here. Tell me when you can see that. And we're actually going to go to this one. So we all see that? Okay. So when we're talking about the shoulder impingement, we're really talking about the impingement, meaning pinching of the rotator cuff muscles. So this obviously is the back of your body. So you're going to see these superficial muscles here. These are the trapezius, the upper trapezius, middle trapezius. You see the deltoid, which is a superficial muscle also that makes up the shoulder. You have the latissimus dorsi, which is another of your superficial muscles that you can feel. But if you remove those muscles and you start getting deeper, what you're really looking at is the shoulder blade. And the shoulder blade itself right here has quite a few muscles that attach to it. Okay. And the muscles that you're seeing from here being the supraspinatus, the infraspinatus, teres minor and teres major, these make up your 4 rotator cuff muscles. You have another one that's on the undersurface of the shoulder blade, but it's on the other side. So if here's your shoulder blade, it's tucked between the shoulder blade and the chest wall, the thoracic wall. So it's underneath, you can't see it at this position. And that's a subscapularis. So there's really 4 main muscles, the teres minor and teres major that are here, they consider together, but they actually are separate. But the reason I'm showing you this is mainly to show you this top muscle, the supraspinatus. And it actually goes underneath this bone. And that bone's called the acromion. And that is what gets pinched between the shoulder itself and the bone above it, that acromion. You get a pinch occur. Okay, but we'll get into this a little bit more. I just wanted to make sure we have a loose understanding that we have certain muscles that are in play, the rotator cuff muscles, but this supraspinatus, that tendon that comes down to the end, is usually the one that gets pinched, that's creating a lot of the pain that's in the front of the shoulder. So let's stop sharing there. Let's go back to our screen. And what we're really talking about again is that pain that you're getting in the front of the shoulder. So when we're talking about shoulder impingement, what does it consist of? What type of symptoms are you getting? What type of presentation are you expecting? So the main symptom of shoulder impingement is really a sudden pain in your shoulder when you're lifting your arm out to the side or overhead or behind the body. So you're getting a sharp, sudden pain with any of those. The other symptoms that you might get are minor but constant pain in the shoulder, sometimes out to the side. It's kind of a dull ache. That pain that goes from the front of your shoulder to the side of your arm, somewhere into here. So it starts in the front and then it kind of leaches out to the side. that can be shoulder impingement. Shoulder impingement symptoms typically are worse at night. So as you're getting ready to go to bed, but that's not because night pain is created. It's more of the activity you've done cumulatively throughout the day. And now it's starting to ache to the shoulder and you're noticing it. But at the later stages of shoulder impingement, what you'll also notice is weakness. You'll get shoulder or arm weakness. You try and lift things out to the side. You try and lift up overhead, and you're just noticing that you can't. For two reasons. One is pain. It just hurts too much. So you can't really push through the pain. Okay. So what really causes shoulder impingement? Okay, we're going to go back to the video, to the pictures in here in a second. And I got a video to show you as well. But when we're thinking about shoulder impingement, what I want you to think of is those rotator cuff muscles, but also an overuse effect. Many times, the reason that you're getting shoulder impingement is either an acute trauma or overuse. But more times than not, it's overuse. The acute trauma can be that you've slept with your arm like this, and it's closed down the interval and created a pinch. But even still, you might wake up and it's just a light soreness. You keep doing that every night over and over and over and over, it can create that. Okay. So think of what I've heard a lot in the VPT group. What's the one exercise you guys hate doing? Side planks. Okay. Is that correct? Side planks. Hey, Kelly.
Hello, sorry I'm late.
You made her. Hey, we're going over shoulder impingement. Just to give you a heads up. Yes, chicken wing, chicken wing. But side planks typically are an area that people do not like. And I'm one of them, because anytime I do side planks, all that pressure that's on my shoulder, I eventually get shoulder pain. And it's essentially creating impingement. So for a lot of you, I've just eliminated shoulder planks right out of your program because it just leads to shoulder pain eventually. Okay. But let's return back to our sharing our screen. Tell me when you could see it. Okay. We went through these. This next slide is very similar. It just has the diagram on there so that you guys can see the different muscles that are included in it. But as I was talking about, you've got those main muscles that are here from the infraspinatus, supraspinatus, teres minor, major. But I also want you to see some of these deeper muscles. Okay. These rhomboids are really important. And the one that's not shown in here is underneath or attached to the ribs and comes up to the front is called the serratus anterior. And I'll get into those in just a second. So when we're talking about shoulder impingement, it's impinging. It's creating a pinch effect to the rotator cuff. So if this is the front of the shoulder, so I'm looking straight on, you can see that this bone that's up at the top of the shoulder, that's the acromion. That's the bone right on top, that if you tap on the top of your shoulder, you can feel that hard bone. That's the acromion. That's the top house of the shoulder. But right underneath it is where your supraspinatus muscle and tendon come down and insert right on the front of the shoulder. So when you're looking in here, it's coming from this fossa back here under that bone, and it's attaching to the front of the shoulder here, right in the front. So for individuals that develop shoulder impingement, they've caused trauma to the supraspinatus tendon at that point. So you can see in this diagram here, what you're getting is that tendon that comes through, and now there's not a space there. That interval has shrunk for whatever reason, and now you're getting pain. So to give you an idea, this space for that tendon to run between the tendon and the top of that acromion, the amount of space is about 2 millimeters. Super tiny. I mean, think of 2 millimeters. That's all the extra space you get. So if you create anything that causes trauma there, so I'll give you an example, sleeping with your arm up like this, it closes that interval and creates a mild pinch. Some throwing activities where the arm whips a little too much and hits to the top. Lifting activities where you're taking groceries and trying to lift them into the back of the truck. Any of that can reduce that space to where that tendon hits the top of the acromion, and then it creates a pinch. And all it takes is a little bit of irritation, and now the tendon swells. Now the tendon's irritated. So now just lifting your arm out to the side, it gets close to that bone. It hasn't even touched it. Now it's irritated. And now it's biting at you. Now it's a sharp pain every time you try and lift up in the head or out to the side or anything with any type of weight. So one of the main reasons we get shoulder impingement is from that acromion hitting that supraspinatus tendon. It could be through the direct trauma that I talked about, a fall to an outstretched hand, or overuse. So I'll give you that example. When you do the side plank, the arm's out to the side just like this, and now all of your body weight is being pushed directly up into the glenohumeral joint, which now you're trying to stabilize your whole body there. And that muscle's having to work. So what's occurring? It's room for impingement, creating pain. I don't like the side plank. Do you see it? Okay. What we haven't even talked about yet is really the kinematics. Okay. So we have certain kinematics to the shoulder. And what I mean by that is kinematics are essentially just study of movement, how the body moves. So we have the shoulder here, and then we have the shoulder blade. Shoulder, shoulder blade. And what we see is the movement of the arm up overhead, but what we never see is actually how the shoulder blade moves. If I took the joint just here, this glenohumeral joint where the shoulder connects to the shoulder blade, there's about 90 degrees that actually moves right there. Only. The rest of the movement, which is 180 all the way to the top, the rest of the movement comes from a little bit here from this AC joint and the rest from what we call the scapulothoracic joint from the shoulder blade. So the shoulder blade and the shoulder actually have to work together to be able to lift your arm up overhead. And that on the next video I have for you, I'll show you that. But right now, what I want you to see is that we developed this painful arc with shoulder impingement. Not all the time, but most of the time when you get shoulder impingement, the 60 degrees to 120 degrees creates the most amount of pain, which is this pinching that occurs. Why does that happen? Why doesn't it get painful always at the top? That's because as the shoulder comes all the way up past this 120, the humeral head starts to depress or come down, and it takes space away from there. So it actually increases the space, the interval of that space. When it's down by the side, it's already below, so it's not impacting. So as my shoulder goes out to the side, it comes up and starts pinching, 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 pinching. Ow, it hurts. At about 120, it keeps coming up, but now it comes down away from it. So that's why at times people say, well, when I lift out to the side, it really hurts. But if I bring it all the way up, it's pretty good. But if I start dropping it over here, oh, it hurts. That's that painful arc. So as a clinician, that's something that we're looking for, is the painful arc in the shoulder. That helps signify that you're getting impingement syndrome versus just a rotator cuff, a torn rotator cuff. But the whole premise of this is the same. We want this pinching to go away. We don't want that pinching. So I already talked about direct trauma as being a cause. I've already talked about improper positions, overuse, creating any type of pinching that creates inflammation. But the one that we also overlook is the kinematics of the shoulder. And if the shoulder and the shoulder blade don't move correctly, it can also create an impingement up overhead. So let's give you an example. Can we all see this video here? Okay, so this is about a 2-minute video. We're going to watch this and then we'll talk about it.
Rhythm is the coordinated movement of the scapula across the thoracic cage, called scapulothoracic movement, together with the movement of the humerus to the glenoid, or glenohumeral movement. Correct scapulohumeral rhythm is required to achieve full upper limb elevation. Scapular superior rotation upon the thorax tilts the glenoid fossa upwards. This change in its orientation accentuates the movement occurring at the glenohumeral joint. This coordinated movement occurs in a predictable fashion, and any disturbance to this pattern is evidence of a muscular or joint dysfunction. Generally, in the first 30 degrees of shoulder abduction, the scapula remains stationary against the rib cage, with the movement occurring only at the glenohumeral joint. As shoulder abduction continues, the inferior angle of the scapula begins to shift outwards as it undergoes superior rotation. On average, there is approximately 2 degrees of glenohumeral movement for every 1 degree of scapulothoracic movement from this point. This means that as the upper extremity moves on through abduction to 90 degrees, the glenohumeral joint contributes 40 degrees for a total of 70, while the scapulothoracic joint has only contributed 20. This ratio continues above 90 degrees, so that by the time the arm has been raised to 150 degrees, the contributions of each joint would be 110 for the glenohumeral and 40 for the scapulothoracic. The actual ratio can vary during different portions of the arc of elevation and can be different from individual to individual.
So what I want you to see from this is see how as the arm starts initiating coming out to the side, it's mainly shoulder movement. There's no real scapular movement. But as the arm starts to elevate out to the side, it goes to almost to a 2-to-1 interval where for every 2 degrees that the shoulder moves, then the shoulder blade moves about a degree. And it starts after about 30 degrees starting to hit that interval level. So the only way we can truly get motion up overhead is with the coordinated effort of the shoulder blade with the shoulder. If we locked the shoulder blade down and didn't let it move, it would be hard to get past about 90 to 100 degrees. It just wouldn't go anymore. So we have to have this gliding out to the side, that shoulder blade as well.
Therefore, it's always important to compare the involved side with the uninvolved. The muscles primarily responsible for the scapulothoracic
So
stability
this is
and
important too,
motion
I'm going to talk
are
about.
serratus anterior, rhomboids, levator scapula, and trapezius.
So again, that serratus anterior is the one I talked about. That's goes along the ribs underneath here and attaches to the underside of the shoulder blade. It's really hard to see. You can't always feel it. It starts along the ribs and then goes right back to the shoulder blade. But these muscles will be very important for what we call upward rotation. So when we're talking about the shoulder blade, it has to glide up and out to get this motion. So we're talking about upward rotation. That's what serratus anterior, rhomboids,
levator scapula, and trapezius. To assess the scapulohumeral rhythm, the examiner observes from behind with the patient standing. The patient is asked to abduct the upper extremity in the scapular plane, which is approximately 30 degrees forward from the coronal plane. The examiner observes for the smooth and coordinated motion of the glenohumeral and scapulothoracic joints.
So essentially, getting into the specifics aren't needed, but what I wanted to show you is this, is those muscles, that levator, that rhomboid, that upper trapezius, that serratus, they work to upwardly rotate the scapula to move your arm up overhead. And the reason that's important is a lot of times we have pain in the shoulder here. We have pain out in the shoulder that's getting impinged. But if the shoulder blade itself can't upwardly rotate properly, it's going to create a pinch effect in the joint. So if any of those muscles, the serratus anterior, the levator scapula, the trapezius, the rhomboids, if they're not doing the job that they need to, if they're not upwardly rotating the shoulder blade, that can create impingement too. So it's not always just direct trauma. It's not always from doing a side plank and pinch, not always from sleeping with your arm up overhead or putting your groceries in the back of a tall truck and getting a pinch in your shoulder. It can be because I'm repeatedly getting a pinch because the activity I'm doing occurs to be a pinch from the weakness in these areas of these muscles or their lack of fatigue resistance. Do we see that? So these muscles here, these scapular muscles, are vitally important to the overall success of eliminating shoulder impingement, which we're going to get into in just a second. So let's go back, and I'm going to open the lines, and we're going to talk a little bit. Let's start with Kathy, and give me your thoughts on that. I just threw a lot of information at you from anatomy, from kinematics, for shoulder impingement, how we get it. What's your initial thoughts on a lot of those?
Everything needs to work together or it doesn't work at all.
Yes.
And it sounds like a lot of things could make even one part not work, so that screw up the rest of it.
Right.
So
Yeah.
Yeah.
Nope, you're right on the money there. And that's 100% because, you know, as a clinician, when we're looking at somebody with shoulder impingement, it's never just clear cut that, hey, oh, well, you lifted your groceries into the back of your car and you got a pinch. Well, just stop doing that. It'll go away. Then how come 6 months later, they're still getting that same type of pain and they just think they have to live with it forever? So a lot of times we have to look at the anatomy. We have to look at the kinematics. We have to look at muscle weaknesses. We have to look and see how the whole rhythm's working together. Because I haven't even touched on the fourth cause of shoulder impingement, which is structural anatomy, which we'll get after right after this break. Lisa, initial thoughts, shoulder impingement.
Well, it's kind of interesting to see how all these different joints are, you know, the joint, the muscles, the tendons. It's a very complicated joint, obviously. So, you know, it seems like it's easy for something to go wrong in there. You know, if you reach out or you grab something and kind of like, you know, sort of like pull or you lift something quickly, it's looks like it's easy for you to cause you know, an injury or at least strain it. So, you know, it's kind of weird. You think, oh, wow, you know, what do? You don't want to, you know, you don't want to do something too much. But then again, if you don't reach out or you don't exercise things, then you lose motion. So,
Yeah,
you know, that's the, you know, that's the problem. But at least for me, you know, not moving around, I tend to not want to move things because when they move, they hurt.
Sure. That's pretty common. I mean, that's why we have pain, is to prevent us from continuing to re-injure ourselves.
Mm-hmm. Yeah. So then when the less you do, you know, then you lose range of motion. So
No, right on. Jill, thoughts on shoulder impingement so far?
Well, from someone who just came out of a frozen shoulder, it's a pertinent topic. So now I'm understanding more as to why it happened. But the same thing, started as a small pinch, thinking I'm going to let it rest, and it froze pretty darn good. So, yep.
And so I'm going to touch on that too in just a second as well. Shoulder impingement and frozen shoulder, why that occurs. So yeah, that's good. Thank you for bringing that up. Susie.
I also had a frozen shoulder at one time. Couldn't lift my arm up hardly any further than that. And hence my little machine or thing back here does help that.
Yes.
And I also heard you should never reach behind your seat in the car.
I have had a lot of people that have been reaching back while they're driving, trying to grab something and hurt their shoulder.
Mhm.
I know. So good. And for our third frozen shoulder person of the day, Kelly.
I'll be right there. Well, I'm the first one to tell you things can go really, really wrong.
Yeah.
So it's really good to have doctors that know what they're doing. And a good start is to go to Dr. Sumner, because even though I didn't believe him, he was right. It was awful.
A little bit of stretching. So with what she's referring to with frozen shoulder, it can start off as shoulder impingement. But what happens is the capsule itself, so what encapsulates the joint, can start tightening down. And that continues to tighten down. Well, what does that do to your interval space now? Now there's even less. There's only 2 millimeters of room there. So what occurs? So when we have frozen shoulder, everything tightens down. Now it's taken your interval, it's even less. So then it just continues to cycle the same level of shoulder impingement to the joint over and over. So then and then on top of it, you have the locked motion and you can't even move out to the side. So it creates a real problem. But the last one I haven't talked about with shoulder impingement can be from the acromion itself. So again, this bone itself that's on top, sometimes it's structured. It's supposed to be flat and straight like this. Sometimes it's hooked. Sometimes it's deformed and hangs down. And when that hangs down, that tendon now is being constantly rubbed by it. And we have individuals that over time will have that spontaneous rotator cuff rupture. They're in their 60s, 70s, 80s, and they go, I don't know what happened. I just woke up and I can't even lift my arm. And they go in and they say, well, you have a ruptured rotator cuff. Well, how'd that even occur? I didn't even do anything. I just woke up and it was like this. And that's because years and years of that acromion coming down and rubbing on that tendon eventually wears it through until it just frays off. So for individuals with frozen shoulder, with impingement, it's important that we take care of this, that we jump right on it and that we don't wait and just have those symptoms continue to ache and ache and ache, because that's essentially eroding down that rotator cuff and wearing it down over time to eventually you're getting a complete rupture. And then you're looking at rotator cuff surgery, which is a challenge as well. So who's at risk for developing shoulder impingement? Who's an individual that possibly could develop this? Well, one, individuals that are playing a lot of repetitive sports. So you look at swimming, you look at tennis, you look at baseball, softball, all those are overhead activities that are repetitive in nature. Okay. Now, for the individual that's done playing sports, they're not really competitive, they're not doing that all the time, they still have a risk of developing shoulder impingement based on their occupation. So construction workers, electricians, working up over the head all the time, constantly hammering, doing all this, that's recipe for shoulder impingement. Moving boxes, constantly carrying and moving things, especially moving and pushing up overhead. Painters, constantly painting up overhead, carrying, lifting up overhead. That's a recipe for shoulder impingement. So both older age and previous shoulder injuries, such as like dislocations, are also risk factors for shoulder impingement. So if you've had a dislocation in the past, that's a risk factor. But the other risk factor, which is even bigger than the previous injury, is that the anatomy of that acromion. If it's hooked and it's hanging down, or if it's sticking on close to that tendon, it can be a problem. So what do we do? How is this diagnosed? How do we know? Well, one area is really looking at how it occurs. So how'd you start to develop this pain? Because it could be just an acute trauma. If it's been prolonged and you've had it for a long period of time, next step would be an x-ray. An x-ray will show the anatomy of that acromion to see if it's hooked or not hooked, because that will be pivotal on treatment. If it's hooked, you might be developing surgery in the future, sooner than later. If it's not and it's normal anatomy, that's good information too, because that means that it's related to something else that's repetitive, that's creating impingement to that rotator cuff. Okay. So overall, the diagnosis is pretty simple. You can usually do a painful arc test and usually just point tenderness right over that supraspinatus tendon insertion. Tells you all you need to know when you have pain there. It's just a matter of how we're going to treat it. So what are some options that you have for treatment? Okay. One is home care. What you do at home, especially when it initially hurts, is critical, such as rest. When it occurs to treating shoulder impingement, when you first develop that pain, whether it's from sleeping poorly, lifting something, when you get that first level of pain, removing those exacerbating factors are critical. So avoiding strenuous exercise or movements that make the pain worse. And that's the key part, because I can give you a whole list and say, well, don't reach behind your back. Don't lift up overhead. Don't carry out to the side. But it really comes down to anything that's causing that pain, that sharp pain, you need to avoid it. Now, it's best not to move or use the shoulder too much when you first get it, but you should really actually avoid using a sling and immobilizing your arm completely. And the reason is, as Jill, Kelly, Susie all mentioned with rotator or with frozen shoulder. Why do we get frozen shoulder? Which is another 4% topic, maybe later this month. But the reason that we get frozen shoulder is through a cascade of events. It's not always predictive that says you're going to get frozen shoulder, you're going to get frozen shoulder. What they know is the association. People that have diabetes have a greater chance of getting rotator or frozen shoulder. People that have had an acute trauma followed by immobilization. So you fall to an outstretched hand, you hurt your shoulder lifting something out to the side, and you immobilize it. You put it in a sling and you don't use it too much. Although you fall to the ground, you get in a car wreck, you don't use your arm. It starts a chain of events that leads to the capsule itself just tightening for its own unknown cause. They can't always say it's because of this, but they do know that if you immobilize after an injury too much, that's one of the causes of frozen shoulder. So we want to avoid activity that causes the pain, but we don't want to completely immobilize. We don't want the shoulder to stiffen up or weaken up. Okay. Obviously, you can definitely ice at any point. That's good. Minimizing trauma is important, but minimizing the amount of exacerbating activities is critical. Okay. Second thing that you could do is different medications. Taking a non-steroidal anti-inflammatory med such as ibuprofen, Motrin, Advil, all ibuprofen, that can help with pain, but also can help with some of the inflammation and swelling that you're getting. Doing those with the ice and the rest that reduces your pain overall is probably your best recipe early on. Sometimes if your symptoms are severe enough, you'll have a physician or orthopedic that will inject a steroid in there as well. The whole purpose of that is to act as a massive anti-inflammatory to just try and get your symptoms down. The other option you have is physical therapy. And the thing that you're looking for with physical therapy that I would look at is I would be wary of the cortisone injection or even jumping to surgery right away. Because if you have the hooked acromion, you have a tightened capsule, you have poor kinematics to the shoulder blade, even with an injection, your pain's going to come back. Even with surgery, your pain can come back. Because without fixing the capsular tightness, without fixing the kinematics and the weaknesses to the shoulder, eventually you're going to return to the same activity that caused the impingement overall. And by doing that, it's going to lead to the same type of trauma. And that's what I see for individuals that jump right to surgery with shoulder impingement. It occurs, comes back a year to two later, if they don't fix those kinematics or those tight capsules. Okay. But the option that they have for physical therapy is this. We're going to look at your overall mobility, your pain exacerbating factors, and kind of the cause why you got here. Is it due to a tight capsule? Is it due to the weaknesses to the upward rotators of the shoulder blade? Is it a rotator cuff issue as well? And the example that I give often is it could be related to posture. So if my posture is neutral and even here, I can lift my arm all the way up overhead. Pretty easy, correct? We can all try this right now. Sit nice and tall and put your arm up overhead as high as you can. Okay, now easy to do for usually. Now take a seat. Rest and kind of slouch forward. Now by slouching forward, now try and raise your arm up. And do you start feeling the pinch? Can you get your arm as high? Not usually. But you'll feel that little pinch and you can only get your arm as high, about yay. So for me, when I start feeling it about here. So what happens if you have poor posture, poor mechanics, is you'll just force it. I can't quite get it. But it's a postural issue. It's a kinematic issue. So it could be that we need to stretch the front part of the chest wall to get you from being here to here. So it opens up your posture so you can actually reach up overhead. We might have to mobilize the shoulder itself and do stretches directly to the capsule to open up the interval in the capsule. We might have to add strengthening exercises to the upward rotators of the shoulder blade so that when you're lifting up overhead, it all glides properly. But the answer usually is all of the above. But from your exam, looking at that and deciding from all of those, tightness in the capsule, kinematics, hooked acromion, symptoms, all of that will kind of dictate the direction that needs to go. But that's why shoulder impingement also is one of the most successfully treated dysfunctions with physical therapy, because it's pretty clear cut that here are the factors. If we start checking off these factors, your symptoms get better. But sometimes they don't. And the reason that they typically don't is when you have that hooked acromion, that's you can't open the interval enough and it keeps rubbing on the rotator cuff. So what do they do there? They do a surgical procedure called a decompression. This is called a decompression surgery, or the medical term is acromioplasty. And this is where they take the undersurface of that acromion and they shave it off. They shave off part of that acromion, and then also where the shoulder, the clavicle inserts, sometimes they do what's called a distal clavicle resection, which if you have that done, you'll wish you just only had shoulder impingement. Because typically that one is so sore and it hurts you longer than your shoulder impingement ever does when they do that. But the whole purpose is to open that interval so you have more room. So surgery isn't always the area they jump to right away with shoulder impingement. It's not usually a surgical procedure, but if they do, it's to shave down that acromion, and it's also to shave down the distal clavicle just to open up the interval. But the whole purpose is to create more space, because this is really a pinchy issue. This is a space issue. So what are some of our exercise do's and don'ts? So when you're looking at exercising, when you're looking at fitness activities, when you're looking at home chores or fitness, what are some exercise do's and don'ts? Okay, so let's go through the do's. We know that one of the reasons this occurs is because there's a kinematic issue from weakness to the upper rotators. So we spend a lot of time focusing on chest muscles, shoulder muscles, but we don't always spend time working on the scapular muscles. So working on the upper back muscles is critical to help prevent shoulder impingement. So working on rows that pull towards you, the TRX that we do with a row, the T-ball, so the Swiss ball, the therapy ball, where you're on your stomach and you lift up to your W's, your Y's, your T's. Those are all important for those muscles. The bent over rows that work the scapular muscles are all important. So any of those that work the back part help. But there's one more exercise that I put on your programs that you wouldn't think is really helping for the shoulder, but it's push-ups. And the reason push-ups help is because the serratus anterior is directly linked to pushing this motion here, which if we remember, the serratus anterior is what's also used for upward rotation with the rhomboid and the trapezius and the levator scapula. So when I put those push-ups on there, don't cuss me out, because they're there for a reason, to help with these type of activities. Okay. So what about the don'ts? Things that we want to avoid are direct overhead presses. So if you look at here, I'm pushing directly up overhead, which really shortens my interval, and I'm putting resistance on it. So that's a recipe for impingement. I had a 1v1 with a individual today, and she asked, why an incline bench? Well, on an incline, we're here at this position, I can push, I still get shoulder strengthening, but it's increasing the interval, so I'm not getting shoulder impingement, versus standing up here, and now it's behind my head, and it's possibly creating pinching. So we want to avoid pushing overhead when it's behind our head like so. And vice versa, when we do pull downs, when we're taking a bar and pulling down with the pulley machine or other, we don't want it going behind our head. That's also force with pull, that's creating a chance for impingement. We already talked about how I don't like side planks. Side planks puts a ton of pressure, all that pressure on one arm on your side while it's trying to stabilize. That's a recipe for shoulder impingement as well. And the last little bit is, if you look at the therapy ball that we talked about, where you're lying on your stomach and you're lifting out. So we have the T's, the W's, and the Y's. If you start going up too high behind you and behind your body, that can also create impingement, especially if you add weight to your hands. So a lot of those we want to avoid while we're lifting. What about at home? What are some things that you can do at home to avoid? Well, one, I already mentioned, I hear a lot where people are carrying groceries and have to pick them up and put them in the back of a truck. So the truck's high and you have to, and sometimes they load those up with those heavier, more sturdy bags now. So you got 20, 30 pounds and you're now lifting up above your head, and look at what my shoulder's doing. Shoulder impingement, pinch with force up overhead. So avoid that. Any type of heavy lifting for you, whatever heavy is, away from the body and up overhead, especially in repetitive nature, will do that. If you're painting, doing electrical work, anything up overhead for a prolonged period of time, try and shoot for just intervals. Don't spend hours working up over here, because that can create shoulder impingement. Okay. And the last one is sleeping. When we sleep, if we sleep with the arm up like this for a prolonged period of time, again, that's shortening the interval to where I can get pain and pinching that occurs to my shoulder. Okay. So let's open this back up. I want to hear your thoughts on the second half of this. We'll start, Kelly's gone, so we'll start with Susie. What are your thoughts on as far as the diagnosis? I talked about shoulder impingement, how that occurs, and some of the do's and don'ts with weight training.
Well, it definitely makes sense not to lift straight up over your head. And painting, that's one of the things I hate to do anyway. But my shoulders used to get so tired, doing a lot of painting overhead.
Oh, yeah. Yeah, I tell my wife often I could never be an electrician. It's just sitting there doing this. I mean, putting in a light bulb's about
Yeah,
all I could do, and then they fatigue out.
that's for sure. So I was wondering about my little machine here that I got when I went to physical therapy, if that is good to do too.
Yeah. So the only, that is good when it's done properly. When we put our back to it and when then we start pulling, when it pulls up behind our head, that can create that same level of impingement. Okay. But doing in front or in a doorway that hangs, as long as it's staying in front, you can do it successfully. The other side too is when we're talking about frozen shoulder, which we'll get to in the future. If the capsule itself is tightened down and you go and do a bunch of stretching, you're essentially, there's no room for that to glide. So it just creates this pinching, 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 pinching. And it can actually make your symptoms worse. So with the frozen shoulder, we actually specifically have to get into the capsule and really stretch out the capsule, then follow it up with stretching. Because if we do just the stretching, it can just keep creating impingement issues and you continue to have pain. And then what I hear is, well, I would do more of the home stretching, but it just hurts too much. And then for a day later, my shoulder just hurts the whole time. And that's because there's not any room for that to lift up overhead. So if you're looking to do that for a maintenance, as far as just maintaining mobility, should be just fine.
So I know the box shoulder stretch kind of gets me when I'm doing that one. So I can't do it as long as I'm supposed to at a time, but.
Let's review that with either your 1v1 or the next time you're in.
Okay.
Sound good?
Yep.
Lisa, thoughts on shoulder impingement as far as treatments?
Well, I don't know. I don't think I've ever had a shoulder impingement, but I do have a frozen shoulder on this side. So
4.
yay.
Yes.
I guess
Yes,
we're on the
4
same,
out of 5.
we're on the same club here, but I mean, mine's been frozen since I was like, I don't know, 15 or something. But you know, obviously I don't, when I do exercises, I can do certain ones on this side, but the other one I kind of go up about here, and then, you know, just only until it stops. So I don't know. I guess we'll learn more when you do the program on frozen shoulder and how to you know, deal with that. So I don't know if it's the muscle or the joint, or it must be some combination of the two. So but you know, on my exercises, obviously you have me very, very low impact, very, very, you know, very mild. So I just move things enough to, you know, kind of move them, but nothing to cause pain, because, you know,
Right.
that's where things, you know, get hard. So
Right. So yeah. No, we'll touch on the frozen shoulder a little bit more, but I mean, since you've had your shoulder frozen for quite some time.
yeah, well, luckily I'm right-handed. Okay, so I mean, for years I've been doing things. I kept range of motion on my right side and, you know, right shoulder, but the left kind of was just, well, I don't need it for most things, so it just became somewhat, you know, what's that word? Well, anyway, it became unused and unusable. So,
Sure.
so, you know, just over time, just lack of use.
Right. Okay. Jill, your thoughts on shoulder impingement treatments?
It's all good. That's what I did to get out of it. So I'm just trying to do stuff so it doesn't happen again. You know, building up strength in those muscles and stuff. So for whatever reason it happened, but definitely glad it doesn't hurt the way it did.
That's why it's impressive. So you do those 1-arm push-ups.
And it's the weak arm. Yeah. Yeah. No, I don't know. It just, I don't know why, but it happened, and just trying to get out of it. So definitely had to go through a lot of pain to get out of it though, too, once it was there.
Yep.
It was not fun.
Yeah. It was fun for me to stretch Kelly's shoulder though.
Yeah, I think it was fun for my PT guy too. Yeah.
All right, Kathy, take us home.
I mainly have a question. You're talking about the ball when you're on your tummy.
Yes.
How about I really like rolling back over my ball, because I feel that opens up my chest.
Yeah. Yep.
Too. But I, you know, I know the front, but that actually feels really, really good when you roll over backwards, you know, to kind of open up the front body.
Yep.
I'm just curious, is that so that isn't
Abs-
impinging anything,
ab-
right?
Absolutely. That helps with your thoracic mobility. I haven't talked about that too much, but if you have poor thoracic mobility, it does allow you to get this thoracic extension, which will allow you to bring your arm up overhead. So that's a small component as well. So sometimes we get in there and mobilize the whole thoracic spine and really stretch that open as well. But I think what we'll do is, Jill, let's put my stretching that I have for the anterior chest wall that we have on, I think, unlisted on YouTube. We'll put that on the replay so you guys can see those videos on how to stretch the anterior part of the chest wall, because those are kind of critical for a lot of different injuries from the neck all the way down to the shoulder to have good mobility there. So yeah, thank you for that, Kathy.
I just question. Okay, thank you.
Kelly, I know you were collecting urine, so.
Hi, well, yeah, I was busy doing bathroom duties, but I did have a question.
Fire away.
You talked about surgeries for the frozen shoulder and stuff.
Hmm.
None of those sounded like what they did for me.
So I was talking about surgeries for shoulder impingement. And
Gotcha.
they'll shave down the acromion. And that's really the main one that they do. Sometimes they'll do a distal clavicle resection. For a shoulder, frozen shoulder, they never do surgery there. The only thing that they would do is open up the capsule and cut it open, but usually they don't have to. What they do is put you under anesthesia, and then they just stretch it all they want. All they want. So while you're under anesthesia, they just.
It was a wonderful thing.
So, well, it's wonderful for the first 12 hours because you can't feel it with that nerve block, but then after that, it's pretty miserable.
Well, yeah, but I don't remember it being horrible afterwards, and it never came back. So life is good for me.
True. So, all
right.
right, team.
Week.
Look for our frozen shoulder in the future. Also look for that replay on the stretching. Other than that, thanks for your participation today.
Sample of urine.
Oh, yes.